So we get a lot of people who come and think they want to do interventional radiology and they think that the diagnostic side is not necessary. Far from it. Actually, you are blind, deaf, and dumb without good diagnostic skills if you want to be an interventional radiologist. I was a surgeon before I joined interventional radiology, and I guarantee you that no surgical skills are relevant in interventional radiology. I found diagnostic radiology training very, very hard. I did my initial radiology residency in Sheffield. I joined radiology wanting to do IR. Halfway through in my third year, I thought I'll do MSK. The only reason was the MSK people are very, very rich, make lots of money. I tried very hard. I just never understood it. I don't think I was intelligent enough to do MSK. So I went back to IR. So I did some vascular IR training at Sheffield, and then I did a further 2.5 years at the Royal Free in London, which is a big hepatobiliary and liver transplant unit in Viva, which means I didn't pass my FRCR exam in the first attempt. So I can give you lots and lots of advice on Viva techniques, and obviously I've given exams in the surgical world. Some of this might be repetitive for you. So when a film goes up, obviously your body language is very important. Do not really focus on the examiner's face. You can get a whole variety of examiners in my, not numerous, but a couple of attempts at the FRCR2B. I came across all sorts. You have the smiling deaf examiner, you'll have the examiner who will mislead you, you'll have one that will have a completely masked face, and sometimes you'll have an examiner who will be very friendly. So I met a set of examiners who said, just sit down and pretend that we are two junior doctors and we've come here to ask for your expert opinion on a series of films. And really, this is the strategy that you should adopt for this exam. So you imagine that you're at your radiology workstation, clinician has come in, they want your expert opinion on a series of films. And that's the mindset that you need to be. I know it's really hard in an exam setting, but you're not going to be asked something very esoteric. You're not going to be asked some fine print. The examiners want to know, do you know your stuff? Are you a safe radiologist? So here's a couple of slides on Viva technique. So a few things that I was taught. So when the image goes up, or this is something that you should adopt in your reporting. So my talk is addressed to both people giving the Viva and to all the junior radiology trainees. So whenever you're looking at an image or a study, think about, before looking at the history, think about why this was done. So why was this study done? Okay. Otherwise, listen to the history if you're in an exam setting. And this is really, really important because, if the patient is male and you give a female differential diagnosis, that means you weren't really paying attention. So again, this is an old adage, where before what? So where is the pathology before what it actually is? So here, good knowledge of radiological anatomy is paramount. So always get the where before what, because the location of the what will help you determine your differential diagnosis. So for example, I'm going to very carefully wander into the chest, which is not my specialty at all, but something that's pleural based versus something that is chest wall or rib based versus something that is lung based, the differential diagnosis is completely different for all three. So where is the bulk of that what? So think about the where before the what. Okay, here's something that, and again, it depends on, in the United Kingdom, this would be very appropriate. If you know the diagnosis, just say it. So for example, if you see a right upper lobe collapse, don't go around the town and give a beautiful description. Just say this is a right upper lobe collapse. The features are as follows: 1, 2, 3, 4, 5. Obviously, you take a big breath, typically give the clinical features rather than, because you want the examiner to go through as many films as you can. The more films you go through, the better you're doing. And this will kind of be relevant to today's situation. Do not ask the examiner too many questions. There's a way around this. There's a smart way that you can do this. So for example, if you're not given much of a history, or if you've come to a point where you need some further information, rather than say, is there a history of smoking? Is there a history of, I don't know, some kind of occupational lung disease? Or if there's a history of trauma, rather than ask these questions, you can turn around and say that in the context, if there's a history of trauma, then I would be thinking of A, B, C. If there's a history of some drug, this is, so you are kind of thinking out loud, making the examiner give you that information rather than turn around to them all the time and ask too many questions, because this strategy can only work for a while. And in a Viva, and this is relevant to Pakistan, I graduated in Pakistan, by the way, from Allama Iqbal Medical College, so I know exactly what it is to be at the receiving end of a Pakistani examiner. I don't think they've changed in the last 20 odd years. So do not ask the examiner too many questions. You want the examiner to be on your side. Don't antagonize the examiner. So therefore, give a sensible differential diagnosis. Okay, do not give, and you don't need to give a very long list, from Daynard or whatever other books you guys are reading these days. A sensible differential diagnosis. If you do not know the final diagnosis, do not get hung up on it, as long as you give 2 or 3 that are roughly what you think it should be. Because in the real world, we would be doing other things to take this further. So sensible, keyword. So therefore, if it's a male patient, do not talk about breast cancer, and vice versa. The female anatomy does not have the prostate yet. Then once you've given your differential diagnosis, if relevant, give an appropriate, I emphasize on the word appropriate, management plan. Now, what could this be? Urgent referral to an appropriate clinical team, urgent referral to, let's say, the tumor board, so an appropriate tumor board if this is a unexpected finding or a cancer, or any unexpected finding should be urgently referred to the appropriate clinical team. So let's say a subarachnoid hemorrhage or a bleed or ruptured aneurysm, something to that effect. Suggest any further relevant investigation. And if you are doing something specialized in intervention radiology, you can hazard a guess as to what procedure is required, but I would not expect this to be asked of you in an FCPS setting. I thought I had something down there. Never mind. Okay, so just to summarize, I'm going to stop here now. So describe the study, sequences, phase, obviously depending on what modality you're shown. Again, how to actually speak in an exam. The more you practice, the better you get. We, the VIC faculty, noticed that those people who volunteered the most a couple of months ago did much, much better towards the end of our sort of series of Vivas than those who never turned up. And I think the majority of pass rates is among the people who volunteered the most. So it's practice that you need. So just a few terms that I'd like to give here. So try to use the word there is rather than I can appreciate, I can appreciate, I can appreciate. It's just a word that doesn't really mean much. So the word there is means I see it. I can appreciate is a little bit vague. Possible, even more vague. So say there is. You see something, right? There is. Rather than the word I can appreciate. I will forgive this today because I relevant findings that will help you clinch the diagnosis or differential diagnosis, the primary finding. By all means, give it, but make sure it's relevant. Give a relevant, sensible differential diagnosis. And then give the further management. Now, you might just have a differential diagnosis. You might want to see a previous film or ask for another view or something like that. That is part of the further management. And then really, really important, and now you're having this face-to-face, is finish the film. How is the examiner going to know that you have finished? So if you are sat face-to-face, slightly turn to the examiner and say, in summary, in conclusion, which means, the candidate is coming to the end of the film. Otherwise, how does the examiner know that you've actually finished? What you don't want in an exam are long periods of silence. So they call, the tumbleweed moment. You can hear a pin drop. You don't want to have any of that in the exam. So this is my, tips for Vivas. And as I said at the beginning, this comes from failing some of these postgraduate exams. So hopefully my, trial and error will be useful to some of you.